Hello viewers, today we discuss an important topic. It is respiratory support, and respiratory support can be divided into two parts. It can be invasive and non-invasive. An invasive method is doing an invasive procedure called tracheostomy. When you do the tracheostomy or a breathing tube is introduced through the trachea, it is invasive method. And by other than this, it is called non-invasive. And non-invasive method is usually done, and it is the safe method rather than invasive. So, non-invasive respiratory support provides a bridge between the simple oxygen delivery devices and invasive ventilation. It can be used in patients who are in respiratory distress but do not have any indication of invasive ventilation, or those who are not suitable for invasive ventilation. And for the non-invasive respiratory support, must be cooperative and able to protect their areas and have the strength to breathe spontaneously and cope effectively. So, you cannot give a non-invasive ventilation in an unconscious patient. And a clinician should avoid using non-invasive support to dying process in irreversible conditions such as end-stage lung disease. And likewise, a failure to respond treatment or further deterioration should trigger a decision regarding intubation. And a delayed invasive ventilation is the consistent is associated with worst outcome. So you cannot give the non-invasive ventilation when patient's condition is so bad and patient is unconscious and there is a patient in contrary to patient wishes. So this is the proper method to give the non-invasive ventilation to any patient, and you can give the non-invasive ventilation by doing the three method. It is called high flow nasal cannuli, one of the method, and another is continuous positive airway pressure, and non-invasive or bilevel ventilation. So in high flow nasal cannuli, it is a device introducing the nasal cannula, and you give the humidity oxygen and air. And it is usually given on this patient which is a type 1 respiratory failure. In type 1 respiratory failure, only the oxygen is deficient and there is no rise of perspiration of carbon dioxide. And you can add the device very comfortably to the patient, and patient can expect his sputum, and you can proper judge the pressure of oxygen also. And in the continuous positive air ventilation, or the second method, the continuous positive air ventilation, in this method, so in this continuous positive air pressure, by these names, you already understand what is this. There is a positive pressure which is introduced through whole the respiratory cycle, such as during inspiration and also the expiration cycle. And usually the pressure is here is 5 to 10 centimeter water. It is not the mercury, it is the water. And in this pressure the alveoli is recruit, that is the collapse alveoli is recruit themselves. So this is the indication of giving this continuous positive air pressure such as pulmonary edema, and also the atelectasis. When there is collapse of alveoli occur, you can give this continuous positive pressure ventilation. So another thing is giving the non-invasive ventilation by giving the bilevel ventilation, that is during inspiration and also the during expiration also. And it is usually given by a turbine ventilator or in intensive care ventilator. So in this level, the air pressure during inspiration is about 15 to 25 centimeter water, and also expiration phase is a lower pressure, such as 5 to 10 or 4 to 10. And in these phases, the ventilation is can be spontaneous. The patient on breath and timed occur at a set frequency. And system that is synchronized with the patient effort and better tolerated and tend to be more effective in respiratory failure. Time breath are used for patient with central apnea. So, we already know that the inspiration is the active process and expiration is the passive process. So, in this level, the inspiration is we give the more pressure, and expiration we give the less pressure. And we try to give the ventilation as the physiological limit. So, give the patient the machine is fit by the patient on breathing pattern and on breathing timing also. So, and the common use of this type of non-invasive bilevel ventilation is respiratory failure due to CPD, and also the pulmonary edema, and obesity, hyperventilation syndrome, and some neuromuscular disorder such as Guillain-Barré syndrome, myasthenia gravis. In these cases, we give this non-invasive ventilation, bilevel ventilation. So when the invasive ventilation is failed, we can shift it to the patient as soon as possible for giving the mechanical ventilation such as invasive ventilation by giving the tracheostomy or other devices. So if you summarize, the non-invasive ventilation, it must be given to the conscious patient, and the patient must have the cough reflex intact, and you must take the patient consent before doing doing this procedures also, and you must give this to the unconscious patient, and if needed, transfer the patient to the ICU for giving the invasive ventilation also. And we can give this non-invasive ventilation by giving the hyponasal cannula, and also continuous positive airway pressure. In that case, you give the continuous airway pressure during inspiration, typically usually 5 to 10 centimeter of water. It is usually given in pulmonary edema, and also the pulmonary arterial test is also. And we can give the non-invasive ventilation at bi level. In inspiratory level, we give the pressure around 5 to 15 centimeter of water, and also the expiration at 4 to 10 centimeter of water. And in these phases, it is commonly given in respiratory failure due to severity, and usually type 2 respiratory failure, and also the pulmonary edema, and also obesity, hyperventilation syndrome, and some cases of neuromuscular disorder. And if needed, we can transfer the patient to ICU for giving the invasive ventilation also. So, my dear friends, thank you all for your patient hearing. Thank you. Bye bye. Tata.